Recording start.
Okay. Hi. We're doing borderline personality disorder, BPD, and the stigma that surrounds borderline personality disorder. So we'll start off by what borderline personality disorder is and the definition. So, the definition of borderline personality disorder is defined as a pervasive pattern of instability of interpersonal relationships, self-image, and effects, and marked impulsivity beginning by early adulthood and present in a variety of contexts. So next we'll look at the differential diagnosis. So sometimes BPD can be confused with bipolar disorder, mood disorders, psychosis, post-traumatic stress disorder, antisocial personality disorder, depression and anxiety. And this is just because BPD has a lot of the same symptoms as these other disorders. So sometimes it can get confused. And so those are kind of some of the other disorders that can kind of look like what BPD is, but they do have some differential things in diagnosis. And so next is characteristics of presenting behaviors. So some characteristics can be chronic feeling of emptiness, a pattern of instability and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. So it's that extreme idealization and that extreme devaluation. And then identified disturbances marked by persistently unstable self-image or sense of self. Frantic efforts to avoid real or imagined abandonment, stress-related paranoid ideation or severe dissociation symptoms, impulsivity in at least two areas that are potentially self-damaging. So that could be impulsivity in spending, sex, substance abuse, reckless driving, or binge eating, recurrent suicide behaviors, gestures, or threats, or self-mutilizing behaviors. And then inappropriate, intense angers or difficulty controlling anger. That could be frequent displays of temper, constant anger, reoccurrent physical fights. Affective instability due to a marked reactive of moods, intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. And then stress-related paranoid ideation of severe dissociative symptoms. You can go to the next.
When looking at the etiology of borderline personality disorder, the exact cause is unknown, but there are several influences affecting brain development that may lead to the development of borderline personality disorder. These include genetic factors, environmental factors, and neurological factors. Studies show that there is a genetic predisposition of borderline personality disorder. Twin studies show over 50% heritability, which is greater than that for major depression. It has been proven that there is a higher rate of borderline personality disorder for identical twins versus fraternal twins, 36 and 35% versus 19 and 7%. Studies have also shown that first-degree family members of individuals with borderline personality disorder are 4 to 20 times more likely than the general population to be at risk for a borderline personality disorder. There are also environmental factors that contribute to the development of borderline personality disorder. Studies show that borderline personality disorder is found in up to 70% of individuals that have experienced maltreatment in their childhood, whether that be physical, sexual, or neglect. Other factors that may contribute to the development of borderline personality disorder include maternal separation, poor maternal attachment, inappropriate family boundaries, parental substance abuse, and serious parental psychopathology. When thinking about neurological factors, neuroimagining studies have shown that borderline personality disorder patients have reported bilateral reductions in the hippocampus, amygdala, and medial temporal lobe. A meta-analysis published in 2005 also showed that patients with BPD had lower performances on neurocognitive testing and attention, cognitive flexibility, learning and memory, planning, speed processing, and visual spatial abilities. There have also been impaired neuropeptide functioning, particularly serotonin, in patients with borderline personality disorder. The prevalence of BPD is about 1.6 of the US population and of 5.9% lifetime prevalence. However, in inpatient psychological treatment settings, borderline personality disorder has a 20% prevalence and 9.3% prevalence in outpatient treatment settings. When looking at the prevalence amongst females versus male, the ratio is about 3-to-1 in treatment settings. About 80% of patients who receive treatment for borderline personality disorder are reported to be women. The age of onset of borderline personality disorder is from adolescence to young adulthood. It is reported that the first symptoms of BPD usually occur in the teenage years and early 20s. However, an onset of symptoms still may occur in some adults after the age of 30. There is limited research on adolescent borderline personality disorder, but children can be diagnosed with BPD as young as the age of 12 if symptoms persist for over a year, according to the DSM-5.
Now moving on to symptoms. So according to the National Institute of Mental Health, people with borderline personality disorder are significantly more likely to self-harm and engage in suicidal behavior. They also are frequently encountered in the emergency department, especially with suicide attempts, and more than 500,000 visits to the emergency room occur each year in the US among those with BPD. The rate of suicide attempts is higher for those in their 20s, but mortality from suicide is highest for those in their 30s. For the DSM-5 criteria of borderline personality disorder, it is defined as a pervasive pattern of instability in interpersonal relationships, self-image, and affects, and marked impulsivity beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following symptoms. Unstable or changing relationships, fear of abandonment, stress-related paranoia, unstable self-image, including struggles with sense of self and identity, substance abuse or excessive spending, anger regulation problems, including frequent loss of temper or physical fights, constant feelings of sadness and worthlessness, self-injury, suicidal ideation or suicidal behavior, impulsive behavior such as unsafe sex, reckless driving, binge eating, and also frequent mood swings. And now moving on to treatment options. Historically, borderline personality disorder has been viewed as challenging to treat, but with evidence-based treatment options becoming more widely available, those with the disorder have seen improved functioning and better quality of life. The two most common treatment options are psychotherapy and medication. For psychotherapy, there are 4 main types of therapies that can be done. First is dialectical behavior therapy. This type of therapy was developed specifically to treat BPD. It is a way to help those with the disorder control their emotional dysregulation, reduce self-destructive behaviors, and learn coping skills for personal relationships. The next is cognitive behavioral therapy. This form of therapy can help with people with BPD identify problematic core beliefs and behaviors that may be creating deceiving perceptions of themselves and others. The third form is schema-focused therapy. This can be done individually or in a group setting. It helps identify unmet needs that have led to negative life patterns, which at some time may have been helpful for survival, but as an adult are hurtful in many ways of your life. Ultimately, SFT focuses on helping you get your needs met and to promote positive life patterns. And then the fourth form of therapy is mentalization-based therapy. This is a type of talk therapy that helps identify thoughts and feelings at any given moment and create an alternative perspective on the situation. This form of therapy emphasizes thinking before reacting. And then the next type of treatment is medications. Medications are not typically used as a frontline approach to treat bipolar disorder, borderline personality disorder, but can be useful in addressing symptoms related to co-occurring mental disorders such as depression or anxiety. Medications such as antidepressants or anti-anxiety medications may help treat some symptoms.
Okay, so looking at the outcomes for the treatment methods we just focused on, we found that borderline personality disorder treatments tend to have higher dropout rates. This is because the forms of treatment tend to take longer to complete. Treatment is typically 1 to 3 years, depending on the method of treatment and how much treatment is needed based on client symptomology. So as you can imagine, the length of treatment is not only time consuming, but also can become expensive. Some clients that we work with might not have insurance, or their insurance might not cover some of the forms of treatment available. And so that can result in some people having to drop out of treatment. Research shows that DBT is effective in reducing symptom severity, self-harming behaviors, and the risk of suicide. It is important to note that DBT is currently the only empirically supported treatment for BPD. With that being said, statistics show that 77% of people no longer met criteria for BPD after being in DBT for 1 year. This shows how effective this form of treatment can be. Lastly, the National Institute of Health has published guidelines stating that medications are not the most effective in providing treatment outcomes for BPD. They can be helpful alongside the different forms of psychotherapy offered for BPD.
Next, I'm going to discuss our hot topic, which is the stigma surrounding BPD. There is a widespread discrimination, prejudice, and stigma towards those with BPD when they try to access mental health services. BPD is known for being highly stigmatized in the mental health setting. This is due to the misconception that BPD is a lifelong disorder that is untreatable. Mental health clinicians often emotionally distance themselves from clients diagnosed with BPD. Many times, stigma occurs when clinicians encounter BPD patients in crisis settings. Because they are not in the settings in which treatment occurs, biased perspectives can be created towards BPD patients. Some common stigmas that impact treatment are questions of validity of BPD diagnosis. A qualitative study done by NELS showed that some clinicians associate BPD as a flaw in character rather than it being a legitimate illness. Some view clients with BPD as morally deviant and will deny treatment. This implies that consumers with BPD are not actually ill or deserving of health care, so they think that their refusal of treatment is justified. Psychiatrists working with adolescents in child and mental health services also express concerns regarding the validity of BPD diagnosis for adolescents because the DSM criteria is adult specific and doesn't take into consideration the developmental stages of adolescence. Another stigma is reluctance to disclose BPD. A lot of psychiatrists choose not to tell the client they have BPD because of the stigma and uncertainty about the diagnosis. Sulzer found most health practitioners diagnosed patients with an alternative disorder like post-traumatic stress disorder or depression. Practitioners reported reasons for providing patients with a different diagnosis included fear of the patient rejecting the diagnosis, protecting patients from stigma, shame, and blame associated with BPD, and enhancing the patient's likelihood of receiving appropriate treatment for their mental health condition. Next is the stigma that BPD is untreatable. A qualitative study performed found some health practitioners avoid working with clients that have BPD based on the misconception that BPD is not treatable and it is not responsive to psychotropic medications. Lastly, individuals with BPD are perceived by many practitioners as emotionally unstable and that they do not want to change.
Sorry. And next we're going to talk about how stigma impacts treatment. Clinicians have struggled in treating clients with borderline personality disorder and have often described them using pretty derogatory terms like difficult, treatment resistant, manipulative, demanding, and attention seeking. While these terms may describe part of a client's behaviors, they're usually based on the treatment provider's prior experiences and assumptions. Without the proper checking of these biases, terms like this can become the justification for stigma and discrimination faced by people with BPD. The stigma can lead to things like early termination of treatment, treatment refusal, and other negative outcomes. Due to the stigma, clinicians may unintentionally view the lower levels of functioning often associated with BPD as intentional behavior. The behavior may also be perceived as being within the client's control, as manipulation, or as them refusing help. Therapists may initiate some self-protective strategies like distancing. This is unfortunate in the case of BPD, given that individuals with borderline personality disorder can be especially sensitive to rejection and may react in harmful ways. This is one example of how the stigmatization by therapists and other treatment providers can directly contribute to negative outcomes. Some research has found that the label of BPD was enough to change the behavior of providers. So I looked at a few studies that focused on the reactions of psychiatric nurses towards patients with borderline personality disorder and found that overall they were far less empathetic toward them than other patients. Clinicians may attribute behaviors of people with BPD to something other than their illness, further stigmatizing the diagnosis. There's also a tendency to take the behaviors of people with BPD and integrate them into the perception of every person diagnosed with borderline personality disorder. Due to the discrimination they often face from treatment providers, people with BPD tend to terminate treatment within the first 3 months. They tend to use multiple services and therapists, and when compared to people with other personality disorders and major depression, patients with BPD tend to receive more psychosocial treatment and try more medicines. Patients with BPD also make up a disproportionate number of hospitalizations, which tends to add to the discrimination they face from providers. This is all sort of a self-fulfilling prophecy. Therapists have a bias towards the symptoms of BPD, which causes them to distance themselves from their clients, which then triggers the symptoms of BPD in said client.
So how can we as social workers avoid perpetuating the stigma of BPD in our practice? Easy things we can do is to be compassionate, demonstrate empathy, listen to a person's current experience. We can validate the person's emotional states, take the person's experience seriously, noting verbal and nonverbal communications, maintain a non-judgmental approach, can stay calm, remain respectful and caring, and engage in open communication about the person's diagnosis, about their response to that. We can be human and be prepared to acknowledge both the serious and funny side of life where appropriate, their experiences and ours as well. We can foster trust to allow strong emotions to be freely expressed. Many people with BPD, because of this stigma, find it very hard to build long-term relationships. People who know about their diagnosis will be usually far less likely to engage in trust relationships with them. So it's really important as their therapists, their providers, that we do everything we can to create a safe environment for them. We need to be clear, consistent, and reliable because, again, because of the stigma, people with BPD are often not perceived to be reliable, and they have a lot of rejection, fears of rejection, reactions to potential rejection. And it's really important, if we want to help the person get well, that we be as reliable and consistent as we can, because any sort of thing that we do could likely be, interpreted by that person as this person is another person I can't trust, and they're going to put their wall up, and then the treatment will be less effective. We need to convey encouragement and hope for them about their capacity for change while also validating their struggles. This particular quote I really liked. It said, the role of the therapist is to reflect the being accepting self that was never allowed to exist in the borderline. So one thing that's really important in working with borderlines is coming from a trauma-informed approach. So trauma-informed care is where we, as the provider, are really understanding how trauma manifests in our patients' lives, and to shape the way that we provide care and the way that we interpret our patients' behaviors around the fact that trauma exists. BPD is a disorder that exists because of a trauma response. So no different than PTSD, DID, other forms of dissociation. All of these things are responses to trauma, and BPD is no different. So this trauma could be something long-standing from early life experience, living in invalidating environment, abuse, neglect, or also they could just have trauma from being regularly exposed to the stigma that we've been discussing. So it's really important that we take a trauma-informed approach to the care of BPD. So it's going to allow space for physical, psychological, emotional safety for us, for the survivor, and for the other people in their circle of support. It's really important that we recognize the necessity that those living with the diagnosis of BPD have a serious mental illness, that it's not emotional manipulation, it's not them faking it. This is something really serious, and we need to help them to create a safe space where they can heal. It's also really important that we be aware as service providers, especially in agency settings where it might be a caseworker, is to remember that that children or other family members of someone with BPD can also be subjected to trauma. There are people who have experienced BPD and their families have experienced that there can be some like some of the symptoms of BPD can be in a way like contagious. So like certain behaviors, if a child is raised by someone with BPD, they might not be a diagnosable BPD, but they're going to have some of those behaviors because that's how they're taught to cope and survive by their parent. So it's really important that we recognize that the condition that children and other family members, other loved ones of people with BPD are living in also can result in trauma, and keep that in mind as we're providing care for the entire family system. Providing trauma-informed care is based on the 4 R's. So we realize the widespread impact of trauma on the people we care for. We recognize the signs and symptoms of that trauma in our clients and consumers. We respond to that by fully integrating our own knowledge about trauma into the care practice and procedures, and we resist re-traumatization of the clients as well as ourselves and other members of the care team. Finally, as social workers, a big part of what we do is advocacy. So how can we advocate for clients and their families? People with BPD experience a great amount of challenges on top of the fact that they have social stigma associated with any mental illness. They have to deal with what we call this particular article called the surplus stigma of BPD. BPD rate of mortality and psychosocial impairment is comparable to like bipolar. However, BPD has received far less awareness, research, and available treatment. There's less money in the system for treatment. There's less money for research. So there's just like this huge space where social workers can help and provide advocacy. There's also a really big unmet treatment need for people with BPD. Most folks, their first especially in the United States, their first introduction into mental health care will be like their GP, their family doctor, and family doctors are very well versed in like, if a person has this particular illness, I'm going to prescribe this particular medicine. As we've illustrated before, borderline personality disorder does not have a really clear way to be treated with medication. So while your general practitioner doesn't need to be a psychiatrist to like know that like if I have a patient who likely has the symptoms of depression, if I give them Prozac or Wellbutrin, they're probably going to feel some symptom relief. That is not the case with BPD. So the average GP is not going to have the skill set in order to provide what that person needs. They're also not going to necessarily have the skill set to recognize borderline personality disorder. And they're even among the mental health profession, as we've seen before, because of the stigma, there's a lot of gaps in like people who are willing to take on clients that have borderline and who also have the skill set to work with them effectively. So it's really important. And then there's also like the money thing again. Medicare, Medicaid programs usually are also again focused on what medication, what's the cheapest way to treat this particular condition. And they're not going to be able to They don't have the space for like, oh, this person needs, you know, twice weekly DBT treatments with a provider who is like on call all the time. And like, that's an expensive, as we said, an expensive endeavor. And it's not how our current for-profit medical system is designed to work. And so that can also be a detriment to providing care for folks with BPD in a way that is actually effective. What happens then is that care is limited to just sort of like crisis management. So in the ER, in giving them medications that may be helpful for certain symptoms, periodic hospitalizations, police well checks, all these sorts of things that are just like addressing crisis after crisis, but not actually working with the underlying issues. So social workers with working with BPD clients definitely need to advocate for more research funding, awareness, and increased skill training in delivering appropriate and compassionate care to this vulnerable population. And we need to actively challenge any stigmas, labeling, rejection, and discrimination about BPD, whether we see it in ourselves, whether we see it in the like internalized in our clients, when we see it among our colleagues and other members of the client's care team, and in their families as well. Given the high rate of suicide and self-harm characteristics of BPD, attention must be given to responding with positivity and empowerment to people with BPD. And why advocate? To quote Dr. Seuss, unless someone like you cares a whole awful lot, nothing is going to get better. It's not.
Okay, so to kind of wrap it up, borderline personality disorder is a serious mental illness that causes an inability to manage emotions effectively. Some people with BPD are high functioning in certain settings while their private life may be in turmoil. And most people with BPD suffer from intense emotions and mood shifts and have difficulty regulating their emotions, thoughts, and impulsive behavior. Research shows that with specialized therapy, most people with BPD notice that their symptoms are reduced and their lives are improved. Under stress, symptoms may return and further support may be needed. Some common co-occurring disorders include things like depression, bipolar disorders, substance abuse, eating disorders, and anxiety disorders. And about 20% of people admitted to psychiatric hospitals have borderline personality disorder, and about 10% of people seeking outpatient mental health treatment have borderline personality disorder. The stigma associated with BPD may predispose mental health workers to minimize functional difficulties or disregard the complaints of their patients, given that those very complaints tend to confirm the stigma.
And that is our presentation. And here's our references. Thank you very much for your time.